Hi, my name is Ian Harris. I'm a Professor of Orthopaedics at the University of New South Wales in Sydney, and I'm talking to anaesthetists about the Australian rotator cuff trial, or the ARC trial. The background of this is that rotator cuff surgery is very common and increasing, and yet a recent Cochrane review tells us that there may not be any benefit to this surgery for degenerative tears compared to non-operative treatment. What we propose to do is a placebo-controlled trial comparing rotator cuff repair to no rotator cuff repair. The aim of the study is to determine the effectiveness, safety and cost effectiveness of arthroscopic rotator cuff repair compared to placebo surgery in improving shoulder pain and function and quality of life. Now, it's a blinded RCT. All patients will receive arthroscopic surgery. Some of them will also receive other procedures, like they'll have a debridement, or they may have their biceps tendon tenodized or excised. But they will not know whether they had a rotator cuff repair or not. It's patients between 45 and 75 with a full thickness degenerative tear. Now, the first thing to point out is that their surgical consent will not be a standard surgical consent. First of all, they'll be signing a consent for the trial. So, I mean, all patients will know that there's a 50-50 chance of repair. They understand what that means, and they obviously volunteer for the trial. That's a separate consent. But the consent for surgery that normally gets looked at during the timeout will say arthroscopic surgery to the shoulder with debridement, bicep surgery and rotator cuff repair as indicated according to the ARC protocol. So the consent form won't say whether they're going to have a rotator cuff repair or not. That will also be written in the op report. So the op report, and preferably if the anaesthetist could please write in their own notes arthroscopic surgery according to the ARC protocol, and don't write down whether a rotator cuff repair was done or not, because we need to keep everyone outside the operating room blinded. So this is what happens. We consent them, then they go for surgery, and randomization occurs in surgery. That's why it's important that I talk to the anaesthetist. Randomization needs to occur in surgery because we need the surgeons to tell us whether the patient is eligible or not, and they will only know that once they've looked at the cuff tear intraoperatively. Also, by randomizing as close as possible to the time of the intervention is a better way of doing randomization, so there's less crossovers and dropouts. Now, the randomization is important because for most of our sites, the anaesthetists will be have agreed to do the randomizing, and it's all online. So this is what it looks like, and you will use the surgeon's phone. They've all got an app which does this. You can use a laptop. Actually, anything is fine. And you sign in. This is the demo, but there'll be a real one. So you sign in, and then there'll only be one active trial, and that'll be the ARC trial. And so you click on the green button to get going. And this just says how many patients have already been randomized, but you click on the red button that says randomize new patient. When you click on that, there are some things to fill out. There's an ID number which we give the patient beforehand, and everyone will know. You have to choose a site. We're hoping that will, I think that will actually just say UNSW for everyone, because we're not randomizing by site. We're stratifying by surgeon, not site. So you need to put in the age and whether they had bicep surgery or not, and the surgeon. Then you click review and confirm, which is down here. And then it gives you back what you just typed in. And if you're not happy with it, you go back. Otherwise, you click randomize, and it says participant randomized. And this is where you need to look. It's going to say rotator cuff repair or no rotator cuff repair. Now, those two phrases are very similar. You know, it's so crucial that I think you need to read it out loud. You can certainly tell everyone in the operating room, because they're going to be doing the surgery or not. And maybe get someone else to read it to check as well. And then once you're happy, the surgeon's happy, the nursing staff are happy, everyone's happy, this patient is or is not having a rotator cuff repair. And then if it's no, you wake the patient up. If it's yes, then the surgeon goes on and does the repair. So randomization occurs live. I've said that. Now, once the patient leaves the theatre, nobody is supposed to say anything. So it's not written on any of the notes. The images that are taken go with the surgeon, not with the patient. And they don't go in the patient's notes. So from the moment the patient hits recovery, the recovery staff, ward staff, the patient's relatives, the physios afterwards, no one will know what they had done. And even the people doing the follow-up will not know as well. And in fact, the patients will be followed up by a different surgeon to the operating surgeon. The post-op report will not reveal if they had a repair. The images don't go with the patient or in records. Recovery staff are blinded. Theatre staff should not reveal what they had done. And if you have any questions, this is me. That's my email address and my office number. The other person is Nancy, and Nancy is the project officer. She's doing a lot of the work with this project, and she's also available on that email. So thanks very much for listening.